acetaminophen. 50 million Americans use acetaminophen every week. One would hope that would mean it's a super safe drug. And it is pretty darn safe in good low doses, but not safe at all in too high a dose. So severe liver damage is associated with single doses above 15 grams or chronic use greater than 3 to 4 grams per day. Risk of renal injury is associated with acetaminophen when the patient is also using alcohol or anticonvulsants. It is, as I mentioned at the beginning, has an analgesic ceiling of 1 gram. Alcohol or malnourished states may increase the risk and generally significantly lower this 3 to 4 gram per day limit. Nobody can tell you how much, but just a lot lower. We're not sure of all the mechanisms of action, but it does seem to be an inhibitor of COX-1 and 2 inside the central nervous system. It is not an anti-inflammatory. There are no GI complications. There are no bleeding issues, though it can change Coumadin or warfarin levels. You should be aware it's mixed in to lots of other drugs, Percocet, Vicodins, Fioricets, etc. It's mixed into lots of drugs. When you're taking a history from your patients about the drugs they take, you should specifically ask about over-the-counter drugs because you really need to know if they're using a lot of this. It is available in oral forms, rectal forms, and IV forms. The IV form is really expensive. Another drug is botulinum toxin. Botulinum toxin blocks the release of acetylcholine at the neuromuscular junction, but it also blocks other neurotransmitter release at primary afferent nerve terminals, including glutamate substance P and calcitonin gene-related peptide. These are all pain neurotransmitters. So the fact that botulinum toxin blocks the release of these may have a lot to do with its analgesic effects, such as its benefit for migraine. Its benefit for migraine does not appear to be related to its muscle paralysis effects or its neuromuscular junction, but is probably related to these effects. So there's a growing use of botulinum toxin in myofascial pain and whiplash syndromes. That should be done with great caution because you don't always want to weaken muscles in these syndromes. You may want to strengthen muscles. It's showing up in the use of a variety of neuropathic pain conditions, FDA labeled for the treatment of migraine. It actually seems to be more effective for migraine than it is for tension headaches. Yet another drug is ziconotide. So on the screen over here on the bottom, that is a sea snail that lives on the bottom of the South Pacific Ocean. This snail has a problem because it's a carnivore, meaning it eats fish for lunch. And fish move fast and snails don't. So it has to have a way to get lunch. And it does that via this tentacle. This tentacle is waving out there, and if a fish gets too close, it gets stung by the tentacle. And that fish drops right there, not 10 feet later, which is a long way for a snail. So here you see that fish being consumed by the snail. So the potency of that neurotoxin caught the attention of the marine biologists. I have no idea how you milk a sea snail, but that's what they did, and they got out the toxin, and they stuck it into the mass spectrometers and the gas chromatographs, and they discovered that there's over 1,000 different proteins and peptides in that toxin. They themselves don't know why, but they circled one of the peptides and they said, let's study it. And 20 years later, we have ziconotide. It's a peptide that binds to the calcium channel, N-type calcium channel on sensory neurons. It can only be administered intrathecally via a spinal pump. And it has the benefit that ziconotide and fentanyl are not associated with granuloma formation at the tip of the catheter on pumps. It also has the advantage, I haven't shown it here, it has the advantage that it does not have overdose death, but it does have overdose psychosis, but temporary. And it doesn't really seem to have withdrawal either, so the withdrawal from it can be pretty rapid. So ziconotide binds to the calcium channel, blocking that channel, so there's less influx, therefore there's less release of the excitatory neurotransmitters. When looking at what you can stick inside a spinal pump, there's really only a few drugs that are labeled for intrathecal pump use, and those are morphine, baclofen, and ziconotide. But many others have been studied, and so here the polyanalgesic panel in 2012 recommended doses and concentrations that can be used. Note that ziconotide is on this list. I'll also mention about ziconotide, it is very potent. So the typical starting dose is up to a maximum of 1/2 of a microgram per day. very, very potent. And we increase it typically in doses of 1/2 microgram per week we increase. Typical effective range is between 4 and 10 micrograms per day. Micrograms. Okay, what about muscle relaxants? Lots of different muscle relaxants can be used. So some of the ones that may have a better effect in pain, baclofen, because it's a GABA B agonist. It's actually considered a primary drug in the treatment of trigeminal neuralgia, but is a general good antispasmodic and muscle relaxant. Tizanidine is an alpha-2 agonist, which may give it some analgesic properties besides just being a muscle relaxant. Flexeril or cyclobenzaprine is basically a tricyclic, and you should think of it as a tricyclic. It's very sedating like tricyclics. Metazolone or scalaxin is a very old one, as is methocarbamol or Robaxin, as is carisoprodol or Soma. These are all old. I would say that the Robaxin and the scalaxin are gentler and milder. Soma or carisoprodol should generally be avoided because it metabolizes to meprobamate. Meprobamate, when it was under a trade name, was under the trade name Milltown, was the precursor to the benzodiazepines. So it is a benzodiazepine-like drug, and pretty much the only muscle relaxant that people develop addiction to. So really should be avoided. There's many other choices to use. And then diazepam, which is clearly a benzodiazepine, is a very effective muscle relaxant, but has big problems with dependence and tolerance and cognitive impairment. So is generally not used except for acute spasm situations, short term. Topical medications. Capsaicin can be used in its very potent form. You know, when you go to the drugstore, you'll see low concentrations of capsaicin, but prescription available as a special administration, it's administered in the doctor's office or hospital, is Qutenza. It's an 8% patch, highly painful in its application. Some form of sedation or topical or regional anesthesia has to be used. So again, how capsaicin works is still a bit of a debate. I'll, I think, get into that in a few slides. NSAIDs can be done topically, commercially available as Voltaren or Pennsaid liquid or Flector patches. Ketoprofen is commonly compounded. Topically, ketamine is used quite a bit in creams. Gabapentin can be added to creams. Lidocaine as a patch. It used to be that Lidoderm was the only available patch form. Now it's gone over the counter. Lidoderm is 5%. The over-the-counter ones are 4%. Camphor, menthol, all can be used. They may have some stimulating properties that sort of act to close the gate, we think, by being a counterstimulant. And even opioids can be used in topical form. So capsaicin turns out to be a TRPV1 receptor antagonist. The TRPV1 receptors are only found on pain fibers, C fibers, and some of the A delta fibers. And so they are activated by a combination of heat, acid, or specific agonists. And when you use capsaicin, especially at higher doses, there may be some process that's called defunctionalization of the nociceptor, where the small fiber loses its membrane potential. It cannot transport neurotropic factors. The epidermal terminals in the skin seem to retract. That's irreversible. There's a depletion of substance P, although we no longer think that's the analgesic mechanism. That was originally thought to be the mechanism. Other drugs, you might think about using sympatholytics, alpha-2 agonists, clonidine, terazosin or Hytrin, tizanidine. These are all alpha-2 agonists. They mimic the release of norepinephrine from the descending inhibitory neurons. And again, therefore, they have an inhibitory effect in the dorsal horn. They may block activation of alpha-1 receptors that express themselves after nerve injury. There's an abnormal expression of alpha-1 receptors after nerve injury, and those alpha-1 receptors will be activated by the presence of norepi in the periphery. It could be that by activating alpha-2, we're blocking the release of peripheral norepi and stopping that activation. Beta blockers. Interesting story with beta blockers. In a retrospective study of 873 patients with osteoarthritis, beta blockers was associated with less joint pain, less opioids, and less other analgesics in those patients who had large joint OA. There is growing evidence that there is an interaction with genetics. So we all have what's called the COMT, catecholamineO methyltransferase, which is an enzyme that breaks down catecholamines. And we all have different genetic versions of that enzyme. And if we have a less effective enzyme, you're going to have increased circulating catecholamines, which may predispose the patient to increased anxiety, increased muscle tension, and increased pain. And we may be able to block the effect of those increased circulating catecholamines with propranolol. There's a few studies that support this. The classic one came out actually quite a few years ago now, in 2010. Cannabinoids, kind of the hot topic. Probably at least half of my patients ask me about the use of cannabinoids. So what are the mechanisms of action? Cannabinoids activate endogenous cannabinoid receptors, 1 and 2, cannabinoid 1 and 2 receptors. Both of these have analgesic and anti-inflammatory properties. They may inhibit the release of glutamate, glutamate being the primary pain-activating neurotransmitter. They may inhibit CGRP, another pain-relating neurotransmitter. THC has 20 times the anti-inflammatory potency of aspirin and twice the potency of hydrocortisone. This is in lab studies. We don't really know if that clinically plays out. So in clinical trials, there's mixed results. Officially available pharmaceuticals, Sesamet and Marinol. And in Canada, Sativex, which is a mixture of THC and CBD, is available. Many people think that the mixture of these two is the most effective, but again, we're sorely lacking on studies to clarify all this. So when patients ask me, I give them a lot of I don't knows, but I generally am okay with my patients trying it. I do not encourage smoked cannabinoids. Smoked cannabinoids are probably as bad for the lungs as cigarettes are. Constipation. How are you going to go about treating constipation? So we already talked a little bit about Miralax being an osmotic, lactulose being an osmotic, Colace being a detergent, bisacodyl or Ducalax being a stimulant, therefore more tolerance, enemas, glycerin suppositories, fiber laxatives being good if there's a lot of fluid around in the intestinal lumen, Cytotec being particularly useful with opioids because it helps protect, not opioids, anti-inflammatories, because it protects against ulcers as well as treating constipation. The methylated form of methyl naltrexone, and Amitiza, which is a relatively new osmotic. Analgesics in the elderly. So you have to be careful because these patients often have very complicated medical stories with multiple diseases and multiple medications. So they're more risk of drug-drug interactions, adverse drug effects. A lot of the adverse drug effects increase with age. Higher risk of overdose, higher risk of falls. Elderly patients are particularly prone to anticholinergic effects, sedation, constipation, urinary retention, blurred vision, and dry mouth. So what are some of the drugs that this is prominent in? Tricyclics, antihistamines, antipsychotics, urinary and GI antispasmodics, and muscle relaxants. We have to really worry about falls with benzos, opioids, tricyclics, alpha blockers, antihistamines, any sedatives, any antipsychotics. Drug-drug interactions, very prone if the patient's on HIV drugs or antiarrhythmics. As I mentioned, methadone of all the opioids is the most prone to drug-drug interactions. Cimetidine, any cytochrome P450 inducer, these are some. And lots of drug-drug interactions with anticoagulants. We often want to minimize sedation in the elderly, in anybody, but especially the elderly. So acetaminophen, generally as a pain reliever, it is not as effective as anti-inflammatory. And I think just recently it was taken off the first-line list for osteoarthritis, just in the last few months. But nevertheless, it does minimize sedation and therefore may be a good choice in the elderly. Relatively few drug interactions and adverse reactions. But pay attention to the total amount of acetaminophen they're getting if they're taking other drugs. NSAIDs also minimize sedation, but of course you got to worry about all the other risks of NSAIDs. Particularly in the elderly, you may want to use a protective GI agent such as an H2 blocker or a PPI, or the misoprostol, which is the Cytotec. Tramadol is a bit less sedating, and then also consider using topical agents. Use of NSAIDs in the elderly includes which of the following risks? A, lower blood levels with the same dose. B, constipation. C, increased risk of cataracts. D, increased risk of kidney damage. E, increased risk of kidney cancer. Answer, increased risk of kidney damage. Elderly patients typically develop higher blood levels at the same dose. Constipation is not typically a problem with NSAIDs. Increased risk of cataracts is not an issue, and kidney cancer is not an issue. For opioids, there's generally up to a 4-fold increase in sensitivity in elderly patients, and associated with that, fourfold increase of side effects. So we see that increase in sensitivity, we see reduced clearance, decreased protein binding, smaller volumes of distribution, all increasing the effect of the morphine. With methadone, you see an increased half-life, which is already long, increased cardiac risk associated with the prolonged QT. Meperidine is anticholinergic and has confusion and tachycardia associated with it. So with NSAIDs, you see higher blood levels at the same dose, interactions with anticoagulants, increased kidney damage, increased risk of stomach problems. Start with low doses. I think we are done with this point, so we are good to take a 10